Leeds, and I'm Anthony Leeds, and I am the chair of the Total Diet Meal Replacement Europe organization, which is a body which is concerned with the legislation that controls the composition and other legislative aspects of this type of meal replacement program. But we're also concerned about the scientific evidence, and it's my pleasure today to welcome you to this web seminar, which will be given by my colleagues, by Dr. Kelly Johnston from King's College and LighterLife Limited, and from Professor Mike Lean from the University of Glasgow, and Professor Hamish Simpson from Queen Mary University of London, but previously from the University of Edinburgh. So those colleagues will speak in a moment. In front of you have the programme, which shows you the specific topics that we're going to consider under the heading of the potential for the use of total diet replacement weight loss to achieve return to work. So we will look at the evidence that we have from these trials, and then we will have a brief discussion at the end. If we could move on then to the next slide, which will show you some housekeeping issues. If you have any problems, send an email to this address. Please put any comments and questions into the chat option. We don't have time to take questions at the end of each talk, but we'll put them all towards the end. And if we fail to discuss something that appears to be really important, as I'm sure most of your questions will be, then we will respond by email over the following day or two. There will be a video recording, and we will send you information by email about when this will become available. So we move on to the next one, please. We're really concerned here about the economic consequences of obesity-related problems, rather than the health issues, although for each individual who's affected, of course, the health aspects are the most important. The current focus, as you know from what we're constantly reading about in the media, is the potential use of drugs. And drugs have been important in the past and will be important in the future. But we all have to remember that there is, in fact, a portfolio of options which should always be available to anybody who's giving advice about how a person with obesity can manage their problems. These include diet and lifestyle changes. There are many, many different types of diets, and today we're focusing on one particular diet, formula diets of lower energy intake. But also there are diets which vary the amount of macronutrients and micronutrients, and then also there are the behavioral issues relating to how people eat as well. Obviously, as I've said, there are many medications which have varying mechanisms, and we should not forget the important role of bariatric surgery, which is a very effective way of helping many individuals to achieve a better metabolic state, a better health outcome, and a prolongation of life, in fact. Let's move on to the next one, please. So the first talk today will be given by, we go back one, please, Dr. Kelly Johnston from King's College London and LighterLife UK is going to give us a brief introduction to the evidence for total diet replacement in achieving safe and effective weight loss. Kelly, thank you very much.
There we go. Just waiting to share my slides. Okay. Can we see that? That's all ready to go.
No,
okay,
right. It hasn't come up yet.
No. So I'm sharing. Share.
Right. It will appear in a second. Yep. And
that's there. Okay.
That's it. Very good. Excellent. Thank you.
Thank you, Tony, for that introduction. I'm just going to talk for a few minutes before Professors Lean and Simpson about TDRs, the nutrition, the legislation, really why we know that they're so effective, and just pick up some highlights from some intervention trials. There's been a huge range over the last 10 years just to highlight their usefulness beyond standard weight loss. So what is replacement? So it refers to specialized products which are designed to support weight reduction and which are intended to fully replace all meals or snacks. And we call total diet replacement is known as TDR. If you look at those images there on the right, the nutrient profile of those three images right there are almost identical. And that's because these are formula foods in the same way we have infant formula. These are formula foods which are made up so that they provide very similar balances of macros and micros per meal. These can be made into shakes or soups, rehydrated meals or bars, and it's really important to have a decent range of products that individuals consume, because obviously it doesn't matter how effective a weight loss program is if people don't enjoy the products. Consumers can design their own weight loss program around the types of products that they prefer. types of TDRs. We've got the 800 kilocalorie threshold in the middle there. Below that, they're called diets, and above that, they're called low-calorie diets. A lot of the research studies that have been done in recent years use low-calorie diets, and they come in not too far above the 800 kilocalorie threshold. From a nutritional perspective, the guidelines about how to formulate these are broadly the same. They're both low in carbohydrates, but they're not very low in the way it's suggested you would need to for a keto style diet. You get somewhere in the region of 60 to 80 grams, comes in at about 40% of energy. Same with protein, never less than 50 grams of protein for the day's worth of food. And this is high quality protein with a score of 1. That also comprises 40% of the energy. Fat, essential fats that you would need, comes in at 20%. In addition to that, you have 100% of the full complements of vitamins and minerals, so 100% of the RNI is provided through a day's worth of food, and you have appreciable amounts of fiber. That there's varying amounts added to the different products. So what we know from this is that you can obtain a nutritionally complete diet with a very much reduced energy intake. This type of nutrient-dense diet is extremely difficult to achieve. Food, a TDR delivers this very effectively. The framework around these products is very robust, it's very clear, and you have to meet very specific compositional requirements and labeling rules, and these are all research and which suggests that the appropriate amount of nutrients needed for healthy weight loss. Slightly different prevailing regulations in the UK and the EU, and that's simply because we Brexited before the new TDR came into the EU. The UK uses the energy restricted diet directives, and the EU uses the regulation as mentioned there. There's very small differences between them, but just to advise, if you see products, you might see them with slightly different nutrient balances, and this is because of the differences in compositional criteria. So what's the mode of action of these? If we think of the 800 kilocalorie value I've mentioned, in many individuals that embark on these plans, you're talking an absolute minimum of 1,000, 2,000, probably more in terms of reduction of energy intake per day. It's a huge reduction in energy intake. This facilitates greater weight losses, up to 1.5 kilos, 2 kilos per week. Again, that varies on your starting weight. And the very nature of these types of plans is because of the low amount of carbohydrate in there, 50 grams, it stimulates ketosis, which is where you swap to fat-based metabolism rather than using glucose as your energy reserves. Ketosis is known to suppress appetite via reduced. So if we look at this overall, you see large energy deficits, reduced appetite, very quick weight loss. So we do tend to see very high compliance whilst on these plans overall, and a very low rate of attrition generally, 8 to 12, sometimes longer weeks on plan. The rate of attrition, if it's well managed with involved healthcare practitioners, is extremely low. So just to touch a few findings really, obviously with weight loss, the primary goal is to get the weight off, but it's also to have metabolic improvements. And very low calorie diets and low energy diets previously came under criticism because of the low energy intake, and there's been lots of questions around what they provide the nutritional requirements that you need if you don't lose disproportionate lean tissue, and adverse events, all these other things that crop up. So one of the things that was determined from the CARO study here, which was done a while back now, was the plasma vitamin D levels. In this study, 200 individuals embarked on 8 weeks of a total diet replacement plan, which involved giving them 5 to 7.3 grams of vitamin D3 per day, micrograms rather, with an 8-week food reintroduction. If you look at the y-axis on that graph, that shows you the individuals in this study who had insufficient plasma vitamin D levels. So you're looking at about 50% of patients were coming in with insufficient vitamin D levels. After the 16 weeks, which is the 8 weeks TDR and 8 weeks food reintroduction, you can see significant drops at 16 weeks. And then the maintenance period, which was a year long for these patients, involved either knee exercises, control, or diet, which involved 1 meal replacement product per day with dietary. You can see with the diet plan, the 8% only of that group at that point had vitamin D levels below 50 nanomole per litre. Really remarkable findings from a study of this nature, with the key message here being vitamin D insufficiency was reduced and then further reduced again after 1 year of meal replacement products. And this is a very important finding because in obese individuals, what you often find, there's obviously overnourishment, far too much energy, but actually in many instances, individuals are depleted diet. So there's utility there with these types of products for helping with nutritional status. We move on to the next slide. This is exactly the same study. Difference here is where we're talking about the bone mineral loss per kilogram of fat mass loss. The literature value shows that as being 16.5 grams per kilogram fat mass lost on average. Again, with this study, when we look at the 1 year maintenance period, we saw that it was only 5.5 grams per kilo lost in 11.9 kilos in those doing the knee exercises, and a value in between for those on the control. So again, utility here with these products for actually helping improve body nutritional status. The key message here is that the bone mineral loss was less than the predicted literature value, and it was reduced by 50%. But what's actually important here is it's showing a real beneficial tissue effect rather than blood measures of this. Lean tissue losses, again, this is something that's been postulated as happening. If you lose your weight rapidly, are you losing too much of your lean mass? That's something to avoid. You would wish to avoid any weight loss plan. And this data was presented at the ECO conference last week by Dr. Eve Egan at the University of Surrey. And in this study, there was a group of obese women who embarked on total diet replacement. In this case, it was a very low energy diet of just under 800 calories for 8 weeks. This was the composition of the weight lost at week 2. It shows 44% of this as being body fat, with obviously 56% of this as being lean, which doesn't look good on figures like that. When you break it down, you can actually see that 31% of this was fluid, with only 25% of this as being dry fat-free mass. When we measured this again at week 8, we could see that there was only an additional 300-gram loss of dry fat-free mass, and the vast majority of the weight that came off in those next 6 weeks actually came from fat mass, and some of that with water. So what we can show here is that this TDR results in clinically significant weight loss within 8 weeks, and the fat-free are considerable, but they occur in the first 2 weeks mostly, and a lot of it's attributed to significant fluid loss. And just this, I'm not going to talk about this particular study. These are data obtained from the preview study, which I'm sure most of you have heard of and which you can look up. It's a pan-European study looking at diabetes prevention and weight loss management, and the data was remarkable. What we wanted to show from this is that adverse events is something, again, that people in this study during the LED period, 961 adverse events were recorded, with only 10 of these being reported as serious. And when they were looked at more closely, they were considered as to be unlikely to be related to the intervention. So when you look at the types of adverse events we're talking about here, constipation, headache, dizziness, mostly reported by women, that's worth noting, other than gout, which we saw a high prevalence of in men. But with constipation, it's an interesting one. Diets, you were consuming far less bulk than you would on a conventional food diet. You are not consuming anywhere near the same type of mass. So it stands to reason that you are going to have fewer and smaller bowel movements. In the eyes of the patient, that can often be interpreted as being constipated, when actually you're just passing less through because you're eating less. This is something that if you do feel constipated, that can be managed by over-the-counter remedies, as can most of the other adverse events reported here: headache, paracetamol, exercise, good oral hygiene. So the adverse events are minor and very easily managed when following total diet replacement. Sometimes we know that formulations deliver very great weight losses, far more so than those on a conventional food diet. Weight losses of around 10% can deliver a wide range of clinically significant improvements. You can see some improvements in some people at lower. Weight maintenance generally can be a challenge. That's true of any method of weight loss. But we've got very good data showing that the use of these products during the weight maintenance period is very beneficial and supports weight maintenance, and we've also got health claims in place for that. So we would suggest that formula low energy diet should be considered as a component of the toolkit for management of obesity and obesity-related comorbidities, alongside medications and bariatric surgery. Thank you.
Thank you very much. So with that splendid brief introduction, let's move on now, please, to Professor Mike Lean from the University of Glasgow, who was one of the principal investigators of the direct diabetes remission trial, which has resulted in the adoption of that program by NHS Scotland and NHS England, and is now being rolled out to many thousands of individuals across the United Kingdom. So Mike, thank you very much for participating here, but you're now going to tell us about something which is really very interesting, which is the application of the same type of intervention in a slightly different situation. Mike, thank you.
Yes, thank you, Tony. And I'm very pleased now to be able to talk about this trial. It's only just been published and the results are still under a lot of discussion. And this is a trial called Redirect, and I'll try to explain it. I have some disclosures as usual. And this is the paper which was published just a few weeks ago in Nature Medicine. And this is a trial for remotely delivered weight management using the Counterweight Plus program, which of course includes a weight loss induction phase using a formula diet for people with long COVID and overweight. It's a weightless controlled trial, and I'll explain what that means. Just for background here, long COVID is a self-diagnosed condition. It has many symptoms, but there are a core of common symptoms that most people who complain of long COVID suffer from. There is no known pathology behind it, and it seems to be very much the same as other chronic fatigue situations. In this case, we define it as symptoms which have lasted beyond 3 months from a COVID infection, presumed COVID infection, or sometimes confirmed. It's common. About 10% of people who have COVID, and that adds up to about these are figures from 2024, 1.9 million people in the UK, and there still are approaching that number of people with long COVID affecting them in one way or another. The mean duration of long COVID, 2 years. This is not a trivial hit. And almost a quarter are then too sick for employment, and almost a half have to reduce their employment hours. The cost, I put it on here, the cost of the UK economy is phenomenal. It's got so many noughts on the end that I can't even begin to explain it. And that's loss of productivity plus healthcare costs, which are phenomenal. It's a big drain on the health service and a big drain on the patients and time of general practitioners. So that's the background. There was a call in 2021 from the National Institute for Health Research to conduct research which would help these people. And we started this with a blank piece of paper and said, hello, we have a disease here with no treatment, no established treatment at all. There are very strong links between obesity and having COVID, as I'm sure you know, and by consequence, long COVID. So just over 70% of people with long COVID are also overweight or suffer from obesity, many of them quite severely obese. And these are the most common symptoms: fatigue, pain, breathlessness, brain fog. These are things. These are symptoms which I recognize as being very common in my patients who are needing help with obesity without having been diagnosed as long COVID or anything else. And we know from clinical experience that effective weight management can help those symptoms a great deal. So that was our starting point. Can we put into place a weight management program that would reduce the symptom load for people who have long COVID and who are also overweight? And we decided that we would do this by adapting the Counterweight Plus program, which is now delivered entirely remotely for weight management for exactly those people. And we also did something, I think, unique. First time it's been done using a personalized goal for health improvement to look at effectiveness and health cost effectiveness. And the name Redirect, which there looks like this, and this is because we did a clinical trial several years ago using the same weight management program, Counterweight Plus, to achieve remissions of type 2 diabetes. And that's what it looked like. It was a formula diet for weight loss induction, just as you've heard, and meal replacements were used or were optional for long-term weight loss maintenance. And in that, we achieved a substantial mean weight loss at 12 months, 10 kilograms, and almost half of the patients with type 2 diabetes were free from diabetes by 12 months. So that was Redirect, cunning twist on the name. And this is just one slide from that trial, the Direct trial, which was quite striking, and that is that at 2 years, still 82%, 4 out of 5 patients, 8 out of 10, were free from diabetes if they lost 15 kilograms. And 15 kilograms sounds a lot to some people. They remained very substantially overweight or obese despite losing that. These are heavy people. So the remission rates were much higher than expected and persisted well if people could maintain the weight loss. That was the message from that. And their blood pressures also improved enormously. And these have implications for employability as well. That was what it looks like. It's a very conventional formula diet program for 12 weeks, just as you've heard earlier. Then step food reintroduction every 2 to 3 weeks. This was the most difficult part for our patients to grasp and not to return to their previous eating habits, and then long-term weight loss maintenance using not a high carbohydrate, not a low carbohydrate, an average carbohydrate intake of about 50% of calories, which we find to be most likely to be adhered to in the long term. So people are not good at adhering to unusual or extreme or restricted diets long term. That's what we use. And it was very well accepted. For the redirect trial, we started off knowing very little about long COVID. And so what we did was to go and talk to Long COVID Scotland, a patient organisation, and we did a survey of them and found that a lot of them, they said that the fatigue and breathing problems were the main symptoms that they would like to see improved. And most of them, 75%, were interested in taking up a weight management intervention. So most of the people who were overweight did think it was a good idea. Well received. We involved patients and PPI people in the trial management as a lead, as co-investigators, and on the trial steering committee. And we used a consultation with our patients and the patient group to develop this personalized primary outcome, basically asking the patients which symptom did they most want to see improved. In other words, which was the most troublesome of all their symptoms. And they had many, many symptoms, some of them up to 20 or 30 different symptoms, but the short number of primary ones. They also helped us with the data collection and interpretation. Seems to be repeating itself for no particular reason. Here's the study design. This looks a tiny bit complicated, but if you follow from the left to the right, we recruited 240 people with long COVID and randomized them half and half into those who had the intervention right away and that control group with delayed entry. So they had the intervention 6 months later. And that allowed us to do a randomized control trial for 6 months. And then we followed up everybody for a full 12 months. If you follow that right way through. The program was entirely remotely delivered at home, so these are people with mobility problems and difficulties getting about. So a remote delivery of the formula diet and of a blood pressure machine, and of course, then remote support using digital methods was what we used throughout. The program is supported by professional trained dietitians and named dietitians, so people get to know who they're talking to over the telephone, over the WhatsApp, over the email, or whatever, the Zoom, whatever they're using. And as I say, the data assessment was to ask the patients individually what was their most troublesome symptom, and then list the other symptoms that we were able to gather. Patients were all over the UK with a dominant number in more than expected in Scotland, because I suppose we started recruiting in Scotland, but they're fairly well distributed across the UK. A lot of them in more deprived areas, but with quite a high proportion in the least deprived. Average age 46, mean body mass index 35. So these are pretty hefty people. And the great majority chose fatigue as their dominant symptom. The little map here on the right shows their different symptoms of that they rated with a rating scale. Here's a slide which shows, again, this is perhaps a little complicated. Just looking at the left-hand side, you can see their employment status before they had the COVID. So this is what happened during COVID. And you can see that the people at the top who were in full-time employment, only about half of them remained fully employed after they had the COVID. And those in part-time employment either remained part-time or became other, which was usually off sick. So a lot of our people with long COVID had suffered, their employment had suffered. And on the right, you can see that quite a lot of people here were labelled professional. That is because the recruitment included through the National Health Service. So a lot of our patients were employees of the National Health Service one way or another. And here are the results at 6 months. And we have here two panels. One is the body weight in kilograms, and there on the right is the percentage baseline weight, and they tell you the same thing. In the blue, or is that blue? I think it's sort of blue, are the intervention group, and you can see that most of them lost weight. The average weight loss, 10.3 kilograms. The orange, or brown, were the weightless randomized controls, and they lost only 0.7 a kilogram. So a huge difference in change in weight over that 6-month period, thanks to the intervention. And here is their primary endpoint. And you can see just in the graph here, how at both 3 months and at 6 months, there was a significant reduction in the score of the symptom which they individually rated most troublesome, that they most wanted to recover. And the list here on the left, fatigue, breathlessness, pain, anxiety, depression, or other, those are the primary symptoms. There were very few in the other category, but there were some less usual ones. Anyway, this showed that for the first time, we had an intervention which could improve the symptoms of people with long COVID. There is no other treatment which has so far done that. We looked individually at those major symptoms, and you can see that all of them improved at 3 months, and all of them, with the exception of pain, improved at 6 months. So all those major symptoms got better over that period of the intervention, which was related to their weight loss. We looked at overall quality of life, and again, you can see that these are the panels are above one another here, which show the quality of life improvement, both using a visual analog and a utility score. So whatever way you measure it, it gets better. And then we looked at, on the right-hand side, the systolic blood pressure, and as expected with that weight loss, there was a substantial drop in blood pressure and a small drop, but also significant in diastolic blood pressure. So there seemed to be no downside to this. We looked at the effects, whether there were any treatment effects which altered by age, by social deprivation, by body mass index, sex, or whatever their primary symptom was, and essentially found nothing. So the intervention, the weight management trial intervention, benefited everybody, irrespective of their sort of demographic backgrounds. So that's the story. This is a home-delivered, remotely supported weight management program. It was very well accepted by these people, and they are, in general, difficult people to please. People with long COVID or chronic fatigue syndromes are hard to please. GPs find them very difficult. It generated substantial weight loss, much the same as in other trials, and it clearly affected the symptoms that mattered most to the participants. It was very safe. The numbers here show serious adverse events, and those are people who ended up in hospital for one reason or another out of the 240. 6 were in the intervention group, 10 in the control group. Now, that's not statistically significant, but it's certainly not going in the wrong direction. And their blood pressure, which blood pressure is, I think I'm right in saying, either the first or second most expensive disease paid for by the NHS, fell by more than any drug could possibly achieve, 8 millimeters of mercury across the board. So a useful intervention. And the other thing just to note is that the statistical analysis using this personalized primary outcome has been widely applauded as something which we should now adopt and use in all clinical trials of weight management to look at the battery of symptoms. The major symptoms there we evaluated using validated questionnaires which can be applied to any weight management trial, and I would strongly advocate that they should be included in any future clinical trials of weight management. I mentioned the employment which had fallen during COVID. What was the effect of the intervention on their function and employment? Their employment, and we were able to show that in the intervention group, the hours of work missed, putting all this 240 people together, the hours of work which they missed per week was reduced by 3.4 in the intervention group. So they were back at work for, on average, half a day more across the whole population versus 2.3 in control. So the controls were gradually getting rid of their long COVID, some of them were anyway. And that had a p-value of 0.095. So it's well within the range that may well stand up to scrutiny in a bigger trial. The study was not designed, not powered to look at employment, but that size of difference, getting on average 240 people back to work for half a day a week across the board is a pretty sizable effect. Looking into the future, there are many questions about why the intervention helped these people. The weight loss, we believe, clearly affected them and in several ways, not just their symptoms, but the dietetic support, the potential that personalized intervention contributed valuably to getting back people to work and improving their quality of life is possibly an element in it. We did not include any requirement for a positive test because at the time when the study was done, not everybody was able to get a positive test or do a positive test. That might have changed things. We didn't find any difference when we looked at the people who had had a positive test, so I don't think that's an important issue. It's worth mentioning that in this group, there were many life events in our population. People with long COVID or chronic fatigue syndromes seem to have multiple things that go wrong, of which the most important for this sort of study was loss of income, and I showed you quite a lot did do that. We noted that there was actually rather poor coding of long COVID in the GP records and poor coding of body mass index. And I mentioned that we were told to recruit quickly and to get a quick answer by the National Institute for Health Research. So quite a lot of these people were relatively well educated and white. And behind the scenes, and I should mention this and perhaps we can discuss it later, there was enormous opposition to this trial from one person out of the 240. But the social media picked this up and made this quite an issue because this one person had not appreciated that we said at the very beginning, this intervention is only for people who are overweight or obese and want help with their weight and who have long COVID. And she evidently thought that we were blaming her for the long COVID, and this blew into some sort of noise. And so it's the value of social media is negative in this way. There are the acknowledgements here. Thanks for the funding, thanks to the team and for the participants, particularly the PPI group. And I end on that happy note, and I hope that's novel and interesting for you.
Thank you very much. I've just checked to see if anybody's written any comments or questions in the chat, and that nobody's written anything yet. So if I could encourage you to...
All stunned.
Yes, indeed. Well, this is a really fantastic piece of work, I think, and will prove to be hugely significant. So I'm sure we'll have some discussion.
And you can probably raise the discussion as to whether these results for long COVID apply to the much greater numbers of people with chronic fatigue syndrome or ME or fibromyalgia, none of which have any pathology behind them.
Yes, and actually this relates to something else which we probably will discuss at the end, which is, and I had a conversation with Hamish earlier today when we said that actually GP records don't really record much useful information about employment status, and maybe that is one of the things that needs to be changed for the future. We'll come to that again in a moment, but thank you very much, Mike. That was fantastic. Thank you. Let's move on then, please, to Hamish Simpson, who's going to talk to us about osteoarthritis and the opportunity trial, which was completed last year and published last year. Hamish is now working primarily from Queen Mary College in London, but was previously working from Edinburgh as Professor of Orthopaedic Surgery. Hamish, thank you.
Thanks very much, Tony. I'll just see whether that will share correctly there. Is that sharing okay now, Tony?
Yes, that's
okay. Well, thanks very much for the invitation to speak. And I suppose what we're going from total diet replacement here to total joint replacement. And what I want to kind of talk to you about is, I've outlined in here, is first of all, I'll talk a little bit about the relevance of this to return to work, the effect of obesity on joints, both our own joints, natural joints, and those that we've replaced, and then consider about weight loss after joint replacement, and finally to talk about the opportunity trial and the reason for it. In terms of the relevance, this is actually showing data for the predictions. It's in the US, but actually there's similar type of data for the UK, where we do over 100,000 hip replacements and 100,000 knee replacements every year. But the reason for showing this slide is that you'll see the kind of the mode here. The most common age for joint replacement is between 55 and 64, which is clearly right in the kind of working population. But as this kind of report from the Daily Mail from quite a while ago, 2013, pointed out that the retirement age is set to rise, and it has obviously already gone up and is set to rise further up to 70. And this isn't just in the UK. Many other countries have addressed this, are addressing this. A number have already put them up. Clearly, with France has increased, and other ones such as Denmark are actually heading towards 70, probably by the next decade. So a number of countries have actually will be kind of having a increase in the retirement age, and therefore more people in the kind of working range. And that means that if we then go back to that kind of data we were just looking at, that if the pension age increases to 70, more than 50% of joint replacements will be in the working population. And this is not a small one. It's been kind of estimated that there's a 45% lifetime risk of arthritis of the hip or knee in the population, which means that more or less one in two of us will suffer from hip or knee arthritis at some stage in our life. And in the UK alone, it's estimated to be a cost of over £3 billion cost to the economy each year because of the loss to the working population. So what I want to next move on to is consider the effect of the kind of being overweight or obese on our joints. And this is just to show really from here that when we have a kind of an increase kind of in our weight, there's a kind of a multiplication effect on our joints, because when we are kind of going up activities, because the way our muscles act, and they need to exert actually higher forces than our body weight, that increases the compression on our joints way over our body weight. And this is just showing that during normal walking, this is estimated to be 2 to 3 times our body weight. But during kind of stair ascent and stair descent, it goes up to 3.5 to 5 times body weight. And as you can see here with deep squatting, it goes up to 20 times our body weight. So it's a colossal amount of difference that the weight that we carry has on our joints. And just to bring this is just showing that for an individual going kind of up and down stairs, as it could be 5 times difference, that means that if somebody was just to put an extra kilogram, just the equivalent of a bag of flour around the kind of their waist, the effect of that on the knee joint whilst we're going up and down stairs would be to put a stone of extra load through our knee joint, showing how the kind of the weight changes have such a magnified effect on our joints. What I next want to also just to mention, as well as the large effect that the being overweight has on our joints, is also to mention that the fat tissue has a second effect. It causes an increase in inflammation in the joints, and these two things, both the forces and the increased inflammation, cause a double hit on the joint and increase the destruction of the cartilage. So what I want to do in the next 3 slides is just to kind of demonstrate that also the pattern of people we have now presenting for joint replacement is changing. And these graphs here show on the bottom line in the kind of the browny red here what the situation was in 1980 in terms of the age of people coming forward at the time of joint replacement on the y-axis. And as you can see, most of the people were between kind of around about 75 to 80 when they were coming forward for joint replacement. Although that is still the commonest age as we've kind of gone through from 1990 to 2000, 2010, you can see that those people who were coming forward at a younger age is steadily increasing. And this is actually kind of also backed up by, if we look at what's been happening to the average BMI of the population, this is steadily increased, and now such that by the time we're in the era we live now, that the average of people is we're kind of getting up to 30, so we're into the obese range. And again, looking at this in a series of about 170 patients, consecutive patients who presented to the clinic in Edinburgh here, you can see the large number of people who have a BMI of, in fact, over 50 when they come to joint replacement. So you can see that in 1980, often the age of the patient was 75 with a BMI of 25. By 2015, that had shifted to the age of 60 with a BMI of 30. But now it's very common for us to see patients presenting for knee replacement at the age of 50 with a BMI of 50. And that is a massive increase in kind of burden to the health service, and for a number of reasons, which I'll come on to in a moment. So there is the big effect that we've just been discussing on our natural joints, but what's the effect on joint replacements? Well, patients with elevated BMIs have a poorer outcome. They have higher rates of revision surgeries, and that makes a massive difference, because if you have your primary joint replacement when you're about 75, 80, it's likely that that will see you out through the rest of your life. But if you have this, your joint replacement when you're 50, there's an extremely high chance you'll need that replacing, and that places a massive extra burden on the health service, that we have to do a large number of revision joint replacements because of this increasing rate. The higher BMI, especially people when they're over 40, results in a higher risk of complications such as infection and dislocations. And each infection of a joint costs in the range of 30,000 or so pounds to treat. So a lot of people consider that when they've had their joint replacement, they'll be able to lose weight afterwards. And it's a common perception that patients say to us, as soon as they've had the joint, they'll be able to exercise more and they'll be able to lose weight. But in reality, it just doesn't happen. And this is a study from the States where they looked at 7,000 hips and knees. 70% had no change in their BMI after joint replacement. 12% actually increased, and only kind of 18% had a drop in weight after the joint replacement. So it doesn't actually kind of follow that just having the joint replacement will result in a loss in weight. So if we can't lose the weight after joint replacement, the question then comes, well, what about trying to lose weight before knee joint replacement? And this is just a couple of slides from the Copenhagen group, which kind of Tony's associated with, where they've done a number of kind of nice studies. This was in a group of 192 obese patients with knee OA, but they were not on a surgical pathway, these ones. So they had kind of moderate osteoarthritis, but it was not kind of in the severe category, but of needing kind of joint replacement, but still with significant osteoarthritis. And they were randomized to total diet replacement, either the low calorie or the very low calorie diet, which they had for 8 weeks. And this is showing several things on this slide. First of all, one of the key things to note was that there were a low number of dropouts, so there was high compliance over this 6-week period. And the overall kind of drop in body weight was more than 12% in both groups. And the really kind of interesting thing from an orthopedic surgeon's point of view was that 60% had a good symptom response and a large kind of reduction in pain. So what we then wondered was, well, what about the people who potentially have more severe arthritis because we've placed them onto the waiting list for joint replacement? But could we take advantage of the waiting time before surgery, and rather than it just be a kind of problematic wait for the patient, make the waiting time useful? And particularly if we were to link this, the secondary care episode to kind of weight reduction, whether that would actually help with behavioral change, as there's other kind of studies that have shown that such things as smoking cessation are more successful if you link them to a secondary care episode. And we're taking all those thoughts together. We put together the study called the Opportunity Trial. And this was a preoperative package of care for arthritis, which was a complex intervention consisting of weight loss, orthotics and rehabilitation, and analgesia, which are the kind of the ones that the international guidelines suggest as the most appropriate non-surgical treatment for osteoarthritis. So this was an open label randomized feasibility study. It was carried out in 2 centres in the UK. There were 60 people, average age 67, awaiting knee surgery. And we randomized them 2 to 1 because we were particularly keen to see on the effect in the intervention. What happened was that the patients that had whichever number of these components that was necessary. So there were thresholds set for the exercise, weight loss, analgesia, and orthotics. And if they met all 4, they got all 4. If they met one of those, they just got the one that they needed. But of that, 28 then went into the weight loss component, and the adherence there was 100%, which we were kind of extremely kind of pleased with. At the end of the period, 4 of the 40 in the intervention group cancelled surgery because of improvement in symptoms. This is showing the some of the results. Here, the weight loss has been discussed in some of the earlier talks. From baseline to pre-op, that was from immediately the one's readings prior to them actually going forward for joint replacement. There was on average 11.2 kilogram drop with only 1.3 kilogram drop in the controls. And then the baseline to post-op is the change from in the intervention group in the blue and the control group in the orange between the baseline readings and 3 months post-surgery. And we chose 3 months because we wanted a time point where we could just check for early safety. This was not a long-term study. This was the one for looking for feasibility. But in terms of the knee function, even at this short stage, both it was possible to show that there was better knee function in both the intervention group compared to the control group. This is showing where if the blocks go upwards from the 0 point in the midline, then they have worse knee function, and if they come downwards here, then that's showing better knee function. And you can see in each of these blocks, the grey panels, which were the intervention group, did better. Similarly, if we look at just the more general, not the knee specific, but the general quality of life, it was also possible to show an increase in quality of life. In this one, the scores are the other way around. So the improved health goes upwards and the worst goes downwards. And you can see that there was a large increase in quality of life, which for this type of study with this number was actually fairly remarkable to show a change in this outcome measure. So in summary, what I hope I've shown you is that a relevance to return to work is that there's a high percentage of joint replacement patients are in the working population. And osteoarthritis is a major cause of people being unable to work and a loss to the economies of Europe. The effect of obesity on our joints is not only that we have higher forces and inflammation, which accelerates the destruction of our joints, but also that if the joint is replaced, there's a higher rate of complications such as infection and poorer outcomes and reduced survival time. So with weight loss after joint replacement, there's only 80% or so no decrease, then it's extremely useful to look at ways to try and reduce weight beforehand. And the total diet replacement component in the opportunity study was extremely effective, and the patients, even with this severe arthritis, were able to comply well and get good results. So thank you very much for your attention.
Thank you very much indeed. Thank you. In a moment, we'll come to the question of what to do next. But in the meantime, if all 3 speakers could join together, and Grant, if I could see the next panel discussion slide. Thank you. So we're going to discuss a number of things. If we can go to, that's it. Great, thank you. If we move on to the next one. Questions that I thought we might have time to talk about, but we'll just see how much evidence have we got that obesity comorbidities do actually reduce ability to work, because it does seem to me there's rather a lack of actual hard evidence in the literature, although we all know from clinical practice that this is a problem. And then the evidence that doing something can actually facilitate return to work, again, because the records do not contain information about employment. It's extraordinarily difficult. And then if we conclude after all of that yes, something ought to be done, the question is who's going to deliver it, and when and where, and how will it be done? So those are some of the basic questions. But in the meantime, I've just looked on the Q&A. There's a very important question. Mike, this is for you. Sally Booth says, this is great work. Is there a plan to trial whether non-obese individuals with long COVID would benefit from TDR for its nutritional content and supplement rather than the caloric deficit?
Thanks, Tony. I'm not entirely sure I understand the question here, but by non-obese, I assume she must mean people who are in the technically overweight, but not, in other words, body mass index below 30. And we did include those in the redirect trial. So not everybody had a BMI over 30. I don't actually think the cutoff of BMI 30 is a terribly useful one in any context, but if that's what she means, that it does apply to people who have these symptoms who are overweight or obese. There's obviously no benefit in giving a total diet replacement to somebody who doesn't want to lose weight. Is there any clarification on the question there?
Well, Sally, if you want to write an additional note, we'll come back to that in just a second. But thank you for that response. And could I encourage more of you, please, to write a few notes in the Q&A or the chat section. But let me move on to the next slide, please, because in trying to address those questions, I looked for evidence. There is very clearly very good, very well-documented evidence that people with arthritis are less likely to work. And this is one of the figures that I managed to pick out of the literature from large-scale surveys on household surveys that are done in the United Kingdom. And if you look at the difference between the two lines, the red one being people living without arthritis, people living with arthritis, what you see is that for men on the left-hand side there, and then for women, in both cases at a particular educational level, you'll see that there's more than a 10% difference in terms of the proportion of people who are not in employment. So there is some evidence, but it's not huge. And if we go to the next one, when we come to the question of evidence that intervention can facilitate return to work, I was really surprised because, as you probably know, I've worked with surgical colleagues in bariatric surgery service for a very long time, and know of cases where we've been able to help people to get back to work. Now, I should add at this point, it's very important to remember that work isn't just necessarily employed work. It can also be working in the community and important roles in society. For example, like being a grandparent looking after grandchildren so that the next generation can actually go to work. And Hamish, I'm sure you'll know that, and I've certainly, some of the Copenhagen participants in that trial that you described actually said spontaneously that one of the changes they found was that on losing 12 kilograms in weight, that when they played with their grandchildren, they could actually get up off the floor, whereas prior to losing weight, they couldn't. And this seems like a trivial thing, but actually the practicalities mean that they could then look after their children. Others said, I'm very happy I can now get back on my bicycle and cycle around Copenhagen. All these things about things that are not captured in the evidence, in the formal evidence, in the various surveys. However, looking at this one here, which is one of the ones that I found, it's data from one high-volume surgical centre doing bariatric surgery in the United Kingdom, and it shows that there is actually an increase in 70% of those who are employed, and the numbers are 75 out of an initial overall total of 746, and that overall, if you look at the bottom line, there's a 10% overall, because of course some people who were previously employed are no longer employed, some who are not employed are employed, but overall there's a 10% effect. It would be interesting I haven't found it, but it'd be interesting to know if there's a health economics analysis specifically of that evidence. It would be really good to know that. So in looking at the next slide, please, which I think goes back, that's it, great. Back to the questions. It's really quite difficult to dig out really good evidence. So maybe Mike and Hamish, you could comment on that.
We produced the evidence from the redirect trial, which, as I say, is an unusual one. And this because that particular patient group, long COVID, and by implication, everybody with ME, chronic fatigue syndrome, ability to work is seriously compromised. And the fact that we got more people back to work and got them back for, on average, half a day a week. That is quite a substantial increase. So that worked. I'm racking my brains. I can't think of any good solid trial evidence in other areas, but many of the complications of obesity impair ability to work. Type 2 diabetes or diabetes is still it's a condition which qualifies as a disability. And so if people choose to use it as a disability for getting disability or benefits, then that can be used. And I could tell you a salutary story from an area on the south side of Edinburgh in the direct trial, where a patient with type 2 diabetes in a very poor, socially deprived area lost her diabetes, was no longer diabetes after losing weight, but she then lost her supplementary benefits. And so intentionally put her weight back on so she could once again become diabetic and get her weekly universal credit. And the tragedy was not only that, but the word went through her community, and 2 others in the same category did the same thing. So type 2 diabetes clearly, with its complications, restricts the ability to work. Does weight loss prevent the complications? Well, the evidence from DIRECT says yes, at 5 years, we had a significant reduction in complications, hospital admissions, serious adverse events in the intervention, people who were through the intervention compared to those who didn't. So quite clearly, if you consider being in hospital an indication of not being at work, then we can reduce that with a weight management intervention. Does that help?
Yes, I'm sure it does. Another very specific area where it's quite challenging to help people is where somebody who's a commercial driver, a bus driver or lorry driver, loses their license because their obstructive sleep apnea has got to the point where they cannot proceed. And actually getting those through the NHS process of testing and then a weight reduction and then retesting is really quite challenging. And I've tried to do that several times and found it very difficult to speed it up. It's pretty difficult. So there are some situations. Hamish, did you want to make any comments?
Well, I was just saying that, I think we discussed historically, return to work hasn't been something that's been included as a kind of common outcome in certainly arthritis trials because of, as I showed, they tended to be in kind of older people who might have either be at the end or it may be the cause of why they were kind of stopping work, taking early retirement at the end. But that's clearly not the case anymore. And I think it's actually key to us to include that as an outcome measure in more of the studies that we do, because we need that information. It is going to affect a lot more people. And I think actually joint replacement or just the total diet replacements prior to kind of joint replacement will get a lot more people back to work or back to able to look after others, whether it's their grandchildren or relatives. So absolutely, I think we need to actually get more data on this.
Yes, there's another question that's been written out, which is the question about referral to GP practitioners and the question of whether total diet replacements are considered as treatment for people with arthritis and knee and joint problems. Perhaps you could answer that, Hamish.
It's known as weight loss is known as a kind of treatment for arthritis, but I don't think it's well kind of acted upon because there aren't any particularly good pathways. Certainly in secondary care, I think the surgeons would very much like to be able to kind of refer people, but there isn't the kind of a good pathway for actually allowing them to refer people for kind of total diet replacement. And I think that's kind of one of the big issues that we have. You can probably speak better to primary care than I can, Tony, but I think there's not just to refer people. It's just that the time it often takes for people to be seen is such that they would have had the joint replacement by then, even in today's climate.
Yeah. And then a comment, Kelly, perhaps you could address this one because the Sally Booth, who asked the first question, has come back and commented that she was obviously referring to people who are not overweight, but is actually asking the question about nutritional support. And you've actually shown slides in relation to vitamin D and bone health during weight loss. But I think
I mean, I can see that. It says it's overall, she's asking about the nutritional support gives a significant improvement in overall well-being, especially in low-income individuals. And again, when I speak about the patients, the clients that we have commercially, we have that generation of women, and they are the sandwich generation, as you would refer to them. And they are responsible for caring for their very elderly parents and also doing care for grandchildren. So I think it's a very germane point when we talk about the unaccounted for, level of cost when these individuals are unable to do that. And so often people, especially with the females who do most of the caring, they're obviously very happy to go down a dress size or 2 or 3, but we don't track it, and we should. What you often hear about is, this new, joie de vivre, this new lease on life. They're now able to participate more fully. The emotional well-being that they obtain from following these plans is remarkable. And I think we do need to actually spend more time tracking the nutritional status of individuals that embark on these programs and looking at the improvements that we see. It's not something that's actually done. It's costly, and it's not something that's necessarily considered for funding, but I think it's really relevant. I think it would make a big difference for us to understand where those benefits occur.
Yeah, good. And another question, this one is for you, Mike. Do you think there's a risk that the long COVID symptoms would return if they put the weight back on?
Well, the symptoms will return, but I think what we're looking at here is symptoms which are provoked, revealed, brought out by the long COVID, brought them more into prominence, which were probably, in many cases, our patients did say these symptoms have been there but got a lot worse. It was aggravated by long COVID. So clearly, in many cases, these are the symptoms actually of the obesity, which have been sort of brought into brighter lights. And I'm quite certain that if they regain weight, their symptoms will recover. It became very difficult whether we consider these the symptoms of obesity or the symptoms of long COVID, because essentially they're the same. That's where some of the sort of social media confusion came. So
Yeah.
Difficult question. I mean, I'm quite certain that regaining weight, puts back everything we've improved, basically. And I'm sure Hamish would agree. If you've improved your knee or hip by losing a huge chunk of weight and put it back all on again, then you're back to square one. So the big concern remains weight loss maintenance, and that's where the biggest need for research is.
Yeah. Hamish, the experimental work that's been done over the many decades now on the knee replacements and other joint replacements sort of assumed, certainly for knee replacements, that they were going to go into old people. Now, if we're putting them in people who are aged 50, my understanding from talking to colleagues is that, assuming those people survive 20 or 30 years, it's quite likely that they'd need to have a replacement of the first replacement, and there's not an awful lot of experimental evidence for that. And then if we consider that if they're heavier, I understand that the outcomes may not be as good, and they're more likely to require a replacement. Doesn't that mean that we really should be thinking about really being quite aggressive about weight management in those who have had a knee replacement at a younger age and who were heavy, and somehow get some continuing weight management after surgery?
Well, you're absolutely right, Tony. I mean, it's a massive problem. I mean, even if a person of normal weight has a knee replacement at 50, there's an extremely high chance they will need at least one revision of that knee replacement, if not kind of two. But the kind of double kind of whammy, as it were, with somebody who's overweight is that whereas you might expect kind of a knee replacement to last kind of 18, 20, 25 years, if you are overweight, that's probably kind of reduced by at least a third, if not a half. So you'll get to the stage where you might have even done 3 or 4 replacements, but each one gets progressively more difficult. And you can get to a stage where you can't just keep on replacing the joints, and then people then have to end up either with a wheelchair or crutches or something else. So it is actually a major kind of issue, and something I think we're just getting to terms with, because clearly this change in demographic of the patients has been gradually happening over the last few years. But the large number of patients who we've now got who actually had BMI of over 50 having joint replacement, they are not kind of yet 15 years out down the line. And so it's something that we'll be better off being proactive with now. But as I indicated, it does need something like a kind of TDR post-surgery to get people to lose weight, because just people having the joint replacement, getting more active, does not make them kind of lose weight on their own. So we need to be proactive if we're going to do something like that.
And from talking to other colleagues, in fact, I understand that actually people don't become more active after surgery, do they? As far as we know, they're not suddenly becoming much more active because they've had the knee replaced.
No, there are some people who probably, who the last, year or so have to kind of drop right down, and so they may regain that. But there are some other people who, they don't change their activity level massively.
I could add to that, Tony, that Hamish made the point that people expect or claim to expect that they're going to be more active after having a knee or hip replacement, and they don't. My patients very often say, if only I could lose weight, then I could be more active again. And the evidence from the direct trial was that even with huge encouragement and step counters and heaven knows what to encourage people to take more activity, after losing 15 kilograms in the first 3 months, they didn't. They were no more active. They simply struggled to be active. These are people who remain a long way overweight. And I think we're dealing with a kind of end stage condition here. Our mean body mass index in these trials has been over 30, 33, 35. They still have a body mass index over 30 after losing 10 or 15 kilograms, and asking them to become more physically active just as a non-starter.
Yeah. So in the last 2 or 3 moments, let's just look at these questions again and think, what do we need to do to actually improve the answers to these questions? With regard to gaining evidence, because without the answers to these questions, I'm assuming that insurers and state healthcare providers are not going to be prepared to pay for interventions for which there isn't adequate evidence. How are we going to get a better level of evidence that obesity comorbidities do actually reduce the ability to work? We all know from our clinical practice that this is true, but we've got to actually produce adequate evidence. What needs to be done? Or perhaps it's already been done by somebody and I don't know about it.
Well, I'll certainly chip in again, Tony. I'm quite sure that the major requirement is long-term and even very long-term data, because as soon as we do any of our trials, the first voice that pips up is somebody saying, oh, well, you've only got data for 2 years. What happens after 5 years? Or if you only got data for 5 years, what happens after 15 years? So we need better follow-up. And I think that calls for better use of the routinely collected data that are all held in our health records, but are very difficult to access. They're available, and it just as there are multiple permissions and approvals required to get at them and to analyze them. So I think using data which are being collected under the public purse to look at long-term outcomes is something we should really focus on considerably. The other thing which I mentioned is that to use a battery of tests to look at the symptoms of obesity, it is actually the symptoms of obesity that keep people off work. And that includes pain in your hips and pain in your knees as a symptom of their obesity. I think we have failed to look at employment, but we've also failed to look at their symptoms in a systematic way. So that can be improved quite easily. We have the tools to do it.
Yeah. And then
I'll just say, Tony, it might be possible with linking some of the large national data sets to get some more information about that. I think it will be quite difficult. I think at the moment we probably need better recording of, well, certainly in secondary care in the kind of orthopedic and clinics, in terms of the levels of the BMI and the levels of working, that at the moment we don't record that very well.
Mm-hmm. And then the second question, really, Mike, I suppose I can change this slightly. What would you like to do next with respect to the evidence that you've got from your redirect trial? What would be the next step? What is the next step, if you're allowed to tell me?
Well, I mean, I think the next step that I took was to say, right, we have proven beyond any doubt that we can reverse type 2 diabetes. Are we talking redirect or direct? Redirect. Redirect. Sorry, I'm jumped into direct there, where we have taken it back into community activities. I mean, I think with redirect, then perhaps we need to be a bit more explicit about what obesity is and what that disease process is, and to allow people to understand that the symptoms, which often they attribute to aging, are actually the symptoms which are related to their weight, and they are to some extent reversible. I think that would be the sort of public awareness element of it.
Mm-hmm. Yeah. So, assuming now we can get to a point, delivery is presumably going to have to be in rather a similar way to the current delivery of the diabetes remission program. And I know, Hamish, you and I have discussed ultimately how the opportunity intervention might be delivered. That would presumably have to be in a clinical hospital clinic environment, I guess, because these people are in a surgical program. But if we extend it, it's presumably going to be delivered in a very similar way to the way in which direct is delivered at the present time. Any comments on that?
Well, I think certainly from our point of view at the moment, if we try and refer people through to the dietitian service, it's already overloaded, so that it's impossible to cope. On the other hand, we did find that having a case manager in the opportunity trial was extremely helpful, and I think somebody who the participants could contact, somebody was in regular contact with the participants to make certain that they continued to adhere, was actually extremely useful. So I think the next thing for us would be to look at seeing whether it's cost effective to have somebody delivering this kind of delivering the interventions. And we found that it doesn't necessarily have to be a fully trained dietitian. It's somebody who has actually been taught some of the basics of how to deliver the program, along with some of the basics of the exercise program, which was also a component. Because as Mike was saying, we took advantage of trying to change people's activity level at the same time as actually changing their kind of their weight in that preoperative period. So we got them as fit as possible, but also kind of got them to kind of try and get into the behavioral change aspect, which was so key to hopefully kind of giving them long-term benefit.
Okay. Any final comments before we close? Mike?
I was actually going to ask Hamish or you why you thought the opportunity trial could not be delivered remotely. It's much more cost effective, and people with mobility problems, whether it's arthritis or any kind of mobility or even agoraphobia, are much happier. And a lot of these people with obesity do have these problems, are much happier with a program that they can manage themselves at home with somebody down the phone. And I agree with Hamish there that it doesn't have to be a degree trained, experienced dietitian. It can be somebody who has some basic science and health science understanding and who has training in weight management.
Yeah, Hamish.
So we did do some of the visits were kind of remote, so I think we could actually shift that more to more kind of remote than it was in the initial one, because there's a few people who didn't take part because they thought it was too burdensome. There were too many visits, even though we'd cut them down by half from what was the initial recommendation, and we did the other half online. So I think would kind of look at, and also some of the outcome measures that you were talking about in the redirect trial. I think actually we'd look to see if we could learn from any of those in the design of another study.
Jolly good. We should get together.
Yes, that'd be a good idea. Kelly, any final comments from you?
Yes, I dropped off and I've come back in. I heard what Hamish was saying and what Mike has just said now, and I would agree. I mean, commercial entities have a huge role to play given that, the scale of the problem. And again, they don't have to be classically trained dietitians. They have to be individuals who are motivated. Often people that have been through it are more empathetic, but that's not always required. But a good working knowledge of TDRs, the behavioral change component, we find to be key. But another key thing to pick up on what Mike said, we notice that individuals actually prefer the remote engagement. Yes. That won't necessarily work for everything, but in many instances where we had the option of the face-to-face or the remote engagement, where the remote engagement was an option, it was a very popular choice, and people still do as well. You don't see any big disparities in the outcomes for weight loss, certainly. And again, improved quality of life is something we look at. You can achieve all of that using remote means, which means it's much more scalable in that respect. And I think there's definite use for that there.
Okay. The other thing we're all doing, Tony, is using our research. When we get good research outcomes, and we have, and Hamish has, Copenhagen people, we are then amplifying the benefit for people with overweight by broadcasting this into social media and elsewhere. So in effect, signposting people towards effective methods of weight management, which many of them can access themselves and don't require professional support at all. So I'm getting emails every week from people around the world who said, oh, we read about your research and we've gone off and lost weight by this way or that way, and blow me down, my diabetes has got better, or blow me down, my mobility has got better. So I think signposting and amplifying our research, using social media and every other avenue is benefiting large numbers of people. They won't all necessarily access a formal program. They won't all necessarily go out and buy meal replacements or total diet replacement, but some of them do. And across the world, we're talking quite big numbers now.
Yeah.
Okay, well, I think we should conclude at that point. So thank you very much indeed for 3 splendid, very interesting presentations, some very useful discussion. I think we're at exciting times in all of these areas. So we look forward to finding out what happens over the coming 12 months, 24 months. But thank you very much for your contributions. Thank you to all those who've stayed watching throughout the whole of this meeting and given some questions. And then thank you also to Grant Dunnery at White House Communications, who's been managing the slides and various other things remotely. Thank you, Grant, and the rest of the team. So I wish you all well, and we hope to have another meeting of this type fairly soon, maybe 6 months' time or a year's time. Thank you. Thank you. Bye-bye.
Bye.
Thanks, Glenn.
Bye-bye.